And welcome to another installment of Burning Migraine Questions. I'm Dr. Ziv Peled. I am a plastic and peripheral nerve surgeon with a specific focus in my practice on the treatment of chronic headaches such as migraines. We have many questions and that have built up over the last several weeks as we've changed the format of our program a little bit. We will try to get as many of these taken care of as we can. The program is going to be a little shorter today because I have a previous engagement. So we're going to do about 20 minutes as opposed to 30 minutes. But if it is popular, we can certainly try to address additional questions next time. So let's just jump right in. One patient a little while back said, following an occipital nerve block, or not one patient, one sufferer said, following an occipital nerve block, I ended up with a pronounced dent in the back of my head in the area where my neurologist injected. Apparently this is tissue thinning due to the steroid. My head is quite tender in this area. Is this a common reaction? Does it resolve with time? Anyway, the simple answer to your question is yes. When you inject steroid and you inject somewhat superficially, you can, and this is always a risk with steroid injections, along with tendon ruptures if you're injecting in the hand or in the foot. There is a chance for subcutaneous fat atrophy. We all have some element of subcutaneous fat, and steroids can thin that out. So the fat that you have that is atrophied now is gone and gone for good. So it will not typically resolve with time. However, if it's not too pronounced, there are a number of things that you can do to treat that. Number one, you can excise and cut out the area and just close it to reapproximate the tissues in a more aesthetic fashion. You can actually do some fat grafting. So you can liposuction essentially fat from another part of your body and inject it into that area. I did this for a patient who had fat atrophy from another surgeon's injection in the forehead where it was very pronounced, obviously very aesthetically noticeable about 3 months ago, and she's extremely happy with her results. You can actually barely tell that there ever was a dent. You can even buy certain products if the defect or the divot, the concavity is small enough. You can even buy products off the shelf that are acellular freeze-dried fat that you can then inject. And of course, you can inject fillers such as Juvederm or Restylane, much like you would in the face to fill in various wrinkles. Although those latter treatments are not permanent, whereas fat grafting, either with a freeze-dried component that I spoke about or the autologous fat, meaning fat from your own body, those, if they work, are permanent solutions. Can the nerves that you separate go back together, or can the nerves regenerate? We get some form of that question multiple times a week. And the simple answer to that question is anything is possible. You can win the Powerball as well, but the likelihood is obviously extremely small to the point where nobody really thinks they're actually going to win the lottery when they play or then they buy a ticket. So at the end of the day, when I, for example, have to transect a nerve, I typically cut where the nerve is healthy, so that would be this area, and where the nerve is damaged. So this is downstream, this is upstream, this part is still connected to the brain and spinal cord. This part gets flipped around and embedded way deep in the muscle, and I actually take this part, even though you can technically leave it there, because the chances that this is going to go back here and actually stay there long enough to actually refuse is, again, almost zero. But having moved this back into the muscle, I actually also take this and move it far away and move that far away. So I suppose, again, is it theoretically possible you could have a perfect storm of incidents where these two nerves can meet each other upstream and downstream? Anything is possible, but it is extremely unlikely if you correctly manage a nerve that you cut. And I think that's a very, very important point when speaking with other clinicians as well as patients, to reassure them that nerves can and often are cut in specific circumstances. Obviously, it's nothing that you ever try to do, but there are nerves that you can cut, and if you know how to manage them appropriately once you've cut them, the problems that people talk about as far as chronic pain and deafferentiation pain and so forth are very, very, very uncommon. All right. Along those lines, a neurologist, my neurologist, said he didn't want to cut my nerves because he said I would have a burning sensation all the time and would have to get treatments for that. I'm getting to the point where I will try anything. What would you say? So first of all, obviously, whenever I go to operate on a, let's say, occipital neuralgia patient, the last thing I want to do is to cut a nerve. If you can preserve a nerve, you always try to do that. There's no question that's the case. However, sometimes after years and years of compression, the nerves look like they are permanently damaged. There's a number of criteria that we look at to try and determine what that is the case. Maybe somebody will ask a question about what those criteria are moving forward. We can certainly talk about that as well. But at the end of the day, if you are looking at a permanently injured nerve that you've decompressed, well, leaving it intact, I sort of say to my patients, is much like seeing somebody on the side of the road that's been dead for a month and trying to do CPR. Okay, that person is dead, and no matter how many chest compressions you do, unfortunately, they're not going to come back to life. If they died 2 minutes ago, there's a possibility. If they died 2 months ago, rigor mortis is probably set in, and all the chest compressions in the world are not going to help. So similarly, if you have a permanently injured nerve that you find after you decompress it, you can leave it. And again, I suppose anything is theoretically possible, but it's very likely that that patient will have persistent discomfort to some degree post-surgery. And so in most of those cases, we transect the nerve and cut it and bury it in the muscle again, moving the two ends away from one another. I think when you do that and manage those nerves in that way, the likelihood of the deafferentiation pain or phantom limb pain, if you were talking about something in your hand or your foot, or something that has been termed anesthesia dolorosa, where you have numbness but have pain, the incidence of that is extremely, extremely low. And so it is for that reason that we have those options on the table in some patients. Now, there was an interesting set of questions here. I'll read several of them. One just simply asked, is it true that autoimmune diseases can make occipital neuralgia worse? Another patient asked, how often is it that you see factors such as autoimmune diseases play a role in occipital neuralgia? For example, the myelin sheath being attacked or destroyed by the immune system, thereby exposing the nerve. So let's talk about this for a minute. Nerves can be distinguished along a number of parameters, and many nerves are myelinated. What that myelin sheath is, it's a little covering of cells around the nerves that helps the conduction work a lot faster, okay? So healthy nerves that are supposed to be myelinated work better than, and faster than, but work better than nerves that are not healthy and have disrupted myelin sheaths. Think of the sheath much like the rubber housing on an electrical cord that's plugging in your microwave, okay? That plastic housing that you grab to plug it in and out of the wall is actually not the wire. The wires are inside that, and the rubber housing just protects the wiring inside so that the electricity can flow back and forth from the outlet to the microwave, as we said. The myelin sheath is like that rubber housing, and it allows the conduction of that electricity to go very efficiently. When the myelin sheath is disrupted, or any other number of issues occur, you will have abnormal nerve function. Now, in an interesting study that was done by Dr. Guyron several years ago, he actually did a proteomic analysis and electron microscopy analysis of the terminal branches of the trigeminal nerve, so nerves like the supraorbital, supratrochlear, zygomaticotemporal, auriculotemporal. So he looked at the very downstream branches of those nerves, and he sent them off to the pathologist once he removed them, and they did certain analyses where they could really look at the ultrastructure of that nerve. And I'll read from the paper itself, and this was published, let's see, back in 2014. So again, it's not that new. Basically, the nerves from patients with migraine headaches had a linear organization, disrupted myelin sheaths, and other discontinuous myelin sheaths, which suggested obviously structural abnormalities within the nerves that could perhaps account for the patient's symptoms. Now, in autoimmune diseases, your body attacks itself, and it can attack any number of nerves and occipital nerves are no different. And so this question is an interesting one in that autoimmune diseases can certainly potentially affect the myelin sheath of a nerve and therefore affect its function. Now the question, if you have some type of autoimmune disease, is why does this process disrupt the myelin sheath in one set of nerves and not another set of nerves? In other words, why might you only have occipital neuralgia but not carpal tunnel syndrome or tarsal tunnel syndrome or neuralgia paresthetica? These are all nerve compression issues. And the simple answer is we don't know. There may be a number of other structural issues that are external to the nerve that will affect the sequelae or the consequences of that disrupted myelin sheath. So for example, if there are other structural things outside of the greater occipital nerve, which has a disrupted myelin sheath, that make it susceptible to even greater dysfunction, whereas that doesn't exist in the carpal tunnel, you will have perhaps occipital neuralgia and not carpal tunnel syndrome. But those nuances have yet to be worked out. But it's a very, very interesting question, okay? And I really appreciate that one. It's good. There's another patient that said, we all get the same feedback from our neurologists and docs, and it's confusing as a patient. I've actually had improvement from several decompression operations. That's enough evidence for me, but I need to have some additional work in other areas. When my neurologist talked to me about the fact that this is experimental, etc., I become worried. I start to doubt whether or not I should proceed. I feel guilty about perhaps going against their best judgments, since they're perhaps hopefully good physicians and good clinicians. And you know, what should I do? Why is this such a problem? Well, as I've recently posted, there was a two board-certified headache specialist neurologists. Pamela is actually a member of the International Headache Society, the American Headache Society. She does reviews for the section of neurological diseases at the NIH. A real academician and a board-certified neurologist, obviously, whose only practice is headache medicine. As far as I know, she doesn't do stroke, she doesn't do epilepsy, doesn't do multiple sclerosis, just treats headache patients. And she and Rami have coined this term, unremitting head and neck pain, which basically describes the overwhelming majority of the patients that I see in my office. These are people who have a headache 24/7. If you really drill down and talk to them, they will say, look, I'm never without a headache. It's just that the 3, 4 out of 10, I don't really even notice anymore because I've learned to live with that. It's the 7, 8, 9, 10 out of 10 headaches that really knock me down for the count. If I could live at the 3 to 4, I'd be so happy. And what they go on to expound in this paper, and it's mostly an opinion piece, but obviously a very informed and very knowledgeable opinion piece with a lot of very reasonable hypotheses as to why this may actually occur structurally, based on scientific data to date in both animal models as well as clinical studies. But the idea that these patients actually have peripheral causes for their headaches, in other words, peripheral nerve issues as a cause for their headaches, is one of their contentions. And therefore, in some patients, not all patients, but in some patients, peripheral nerve compression, such as the greater occipital nerve, the supraorbital nerve, etc., can be reasonably thought to be a cause for the headaches. Now, I was actually just corresponding with Pamela today as a little teaser preview for the future. She has tentatively agreed to come on one of our future broadcasts, probably at some point in August. She's extremely busy, as you might imagine, but I cannot wait to have a discussion with her and to hopefully have a lot of people weigh in, because I think she and Rami, and I have to give them a lot of credit for their courage in speaking up for what I think in some circles within their neurology community is likely to be thought of as heretical. And yet I think the data continue to mount and will likely continue to mount that they are right. And in the correspondence we had today, what she iterated to me is something that I've been saying for a very, very long time, which is that many patients have both central and peripheral problems that are ongoing. Most of the patients that we see that have this unremitting head and neck pain and have had headaches for years and years and years have symptoms that are sometimes successfully addressed with medications, which certainly suggest a central process because that's where a lot of these medications act. But in many cases, they don't work consistently or well enough. And I've seen time and time again where patients will have an Imitrex that they take preoperatively, and they say, look, 50% of the time, doc, it works, 50% of the time it doesn't. I could never figure out why. I was taking it 25 times a month because it's the only thing that sometimes works. So when I had a bad headache, which was 25 times a month, I'd reach for it. After surgery, wow, my frequency and severity and duration is a lot less because I only have 5 headache days a month instead of 25 headache days a month. So that alone is awesome. But what's weird is whenever I take the Imitrex, because it always used to work, or it worked half the time now, it always works. And I don't understand, how did the surgery help the medicine become more effective? And the answer is that person likely had both a central problem and a peripheral problem. We obviously have addressed the peripheral nerve compression with surgery. We're not operating inside the brain, and we don't change the chemical milieu within the central nervous system, but that's what medications do. And so these patients now are only taking their Imitrex 5 days a month instead of 25 days a month, but when they take it, it almost always works. So instead of something that's debilitating, they have something that occurs 5 times a month. They take an injection or a pill, they wait an hour, go lie down, and within an hour, their headache is gone or significantly better, and they resume their lives. So we've gone from debilitating to manageable. And I had this interaction, some of you may have seen it online, with another person who was saying that not everyone benefits from surgery, certainly not everyone benefits from surgery. And do we cure and eliminate these horrible headaches in every patient? Certainly not. But I agree 100% with Pam Blake that if we work together, I bet you, much like in a cancer patient, when you have the surgery to cut the cancer out and a little bit of radiation or chemotherapy or hormone therapy to further bolster the effect of the surgical extirpation of the tumor, that's when the likelihood of a recurrent cancer or a metastatic cancer goes way down, and therefore overall the success rates increase. And I think hopefully before I retire, we will see a different paradigm in terms of how we treat headache patients in this country, where we have a lot of plastic/peripheral nerve surgeons, whether they're neurosurgery trained, plastic surgery trained, orthopedic surgery trained. It doesn't really matter as long as they know what they're doing with the peripheral nerves. If they can work with their neurologists and pain management specialists and physical therapists and chiropractors, I think we put all these modalities together, some of these really difficult headache pain patients, and it's not that the patients are difficult, it's that their symptom complex has been difficult to treat. These will be much more successfully treated. So I think certainly peripheral nerve surgery has a role. I think the really interesting thing that I have thought about for many years now is, which came first, the chicken or the egg? Was it a central process that created a peripheral problem? Was it a peripheral problem that, when long-standing enough, eventually caused a central problem? Or do you have two separate entities? And I've had a number of patients who, again, were taking 25 Imitrex a month. We did their surgery. A year later, they're only taking 5 Imitrex a month, very happy. I talk to them because I torture my patients and call them a lot, sometimes years after their operations, just to see how they're doing, because I like a lot of follow-up. And 3 years later, they're only using it once a month. And then at 5 years, it's like, yeah, I can't remember the last time I used an Imitrex. Maybe it was last quarter. And that suggests that a peripheral process was long-standing, may have caused a central process. And that with time, once the peripheral nerves really healed, eventually whatever secondary process occurred in the central system, central nervous system, also eventually died down, and those patients never needed their Imitrex again. And then we have time for one other question. What if compression is done higher up on the scalp? Why is surgery not done higher? Is it because if the damage is higher, excision is best? Sometimes I question if the pain is from whiplash or from a hard blow to the back of my head at a job. 2 years ago, I was working, anyway, they go on to describe their job. I think it's a good question, and there are a couple of answers to that question. It depends on the distribution of your pain primarily, okay? If you have pain in a specific area and it never goes beyond that area, you may have something called a nummular headache. Nummular is just a fancy medical term for coin-shaped. And in that case, you may have an injury to just a terminal branch of a nerve, and so then you can actually do a local operation where you just cut that branch. Most patients have a lot more than that when you really drill down on their pain. And so the reason the surgical decompression procedures that we do are done in different areas is because there have been numerous anatomic studies, some of which, for example, on the lesser occipital nerve I've published, others, for example, on the greater occipital nerve, Dr. Guyron and Ivan Ducic have published, which have delineated where the compression topography of those nerves are. So, for example, if you look at the median nerve, which is the cause of carpal tunnel syndrome, when it is compressed as it passes through the carpal tunnel, there is a space where that compression occurs. It's at an anatomic canal called the carpal tunnel. And similarly, for example, for the greater occipital nerve, there are 6 potential compression points, and you have to look at all 6 compression points in every case, because if you don't, you may miss one. Now, not every compression point is involved in every single patient. Sometimes you look at a compression point, the nerve looks soft, it's pliable, there's plenty of space around there, and then you leave well enough alone and move on to the next compression point. And sometimes patients have compression at each and every one of those points, including way downstream. And so hopefully that clears a little bit of that up. We've gone a little bit over the time that I had allotted today. Please continue to send in your questions. I really appreciate the overwhelming response that we've had to these Burning Migraine Questions, webinars, whatever you call these, Facebook Live events. Please keep the questions coming, and we will keep you updated for sure on whether or not we will actually be able to succeed in convincing Pamela Blake to come on one of these interactions. And I think that would be an extremely worthwhile thing to listen to and to hear. She's got a lot of exciting things going on that I think would benefit a lot of the people on these forums. So once again, thank you very much for tuning in, and we will see you next time for another Burning Migraine Questions Facebook Live event. Take care, everybody. Bye-bye.